Thank you. Good morning and welcome to the fourth meeting of the Health and Sport Committee in 2020. We have received apologies this morning from Sandra White. Can I ask everyone in the room please to ensure that mobile phones are off or on silent, and while it is acceptable to use mobile devices for social media within the room, please do not take photographs or record proceedings. The first item on our agenda is to take further evidence as part of the committee's inquiry into the supply and demand for medicines. We will take evidence from two panels in relation to consumption and waste this morning. I welcome to the committee Adam Stahura, the Head of Policy and Communications with AIDS Scotland, and Claire Fernie, Public Partner Volunteer with NHS 5. Welcome, and can I start by asking you about, as you are approaching these matters from a patient perspective, one of the things we've heard a good deal of evidence on is the importance of patients being involved in decisions about medication. What, in your view, is the current state of play in that regard? Are patients regularly involved, rarely involved? How do you think things currently stand in relation to medication?
Adam Stahura. Probably a bit of a mixed bag across Scotland, and I think it will depend on the type of conditions that the person is living with. I think the big challenge around being involved in the medications is entirely about the length of time that a patient might have with either a GP or even a pharmacist to discuss this, or even knowing that they have the right or are empowered to do so. And I don't think that's a criticism necessarily of GPs or pharmacists, whoever might be having discussions with. They just won't necessarily be as informed as they might otherwise would be about going in and knowing what to ask. So again, it will be a mixed bag. If you're looking at kind of cities where you might not see the same GP, any other than once every 2 years, and the next person sees someone else, or in rural areas where you might actually have more of a relationship with your GP or whoever in that practice, it will have a different outcome for the patient depending on where you might live.
So a mixed bag in your experience. Claire Fernie.
I would agree with that. I mean, I think that you've got groups of patients maybe who have long-term conditions who are very involved and very knowledgeable about their care, and they will be very keen to ask questions. Again, it's about being able to take the time to have those conversations, and also the time to think about making those decisions when you're greeted with options, because traditionally we're used to our clinicians telling us this is what's the right thing for you. We're not used to having to consider different options. And we do find this occasionally with the Realistic Medicines programme still. Some patients are coming out and saying, I expected my GP to tell me what's best for me. He's the expert, and I don't know where I stand now.
So if we were looking to increase the engagement of patients, to put patients more effectively at the centre, is a concern you have that some patients just wouldn't want that?
I think that, yes, I think you can say that for certain groups. I think there are particularly younger patients who have access to much broader sources of information like the internet or whatever, will come in with a lot of information already. But there are still patients who prefer to say, you're the expert, you can fix me, tell me what to do.
Is there anything that can be done, if you like, to address those issues? Are there things that the NHS should be doing more proactively, prescribers should be doing more proactively to encourage patients to engage?
Part of it's about education, that they have, as Adam says, they have the rights to ask and they should be asking. Part of it's about support, that they feel comfortable to speak to their GPs. The Scottish Health Council has recently produced a document about using patient aids for discussion. And some of the things that come out of that are that patients are reluctant to contradict their GP if something's suggested. The carers are not always included in the conversation or even in the room. So a lot of it is making people feel comfortable to ask those questions in the first place, and making sure that the information they get back is understandable to them. It's no point in telling a patient the numbers to treat, for instance. That's not information that means anything to them, necessarily.
Mr. Hura?
I think I'll just back up a lot of what Claire says there, but also thinking about the prompts that might come from the GP to ask, you know, the patient, look, does this all make sense? If you've got any questions about this, you know, these are perhaps the side effects of medication X or whatever. And I think the big challenge in this is the amount of time that GPs have anyway with a patient. So if you're going in to talk about maybe one condition, you have, you know, circa 10 minutes to talk about it and be prescribed, and depending on the culture. But if the GP is then able to and has the time and space and availability to ask the question, you know, not just as, have you got all that, and off you go, which might be the case. But also, there's a very good point about carers, but also thinking about older people who may be living with, say, early stage dementia, maybe not diagnosed yet, and being able to process this information, having the time themselves. There's some really good practice from other parts in the world where after an appointment or even after any kind of diagnosis of something, that they're allowed the opportunity to kind of sit quietly in another room to kind of take time to process what's happened before they kind of leave with a script in hand and off they go to the pharmacy. And equally, it could very well be an opportunity for pharmacists themselves to be available for people to ask a question when they're handing over a prescription, for them to ask them, so do you know what all these things are, to kind of see if there is a sort of doubling up on the same information that the patient has consumed, so they can then make an informed choice, not just about that time, but if it's a repeat prescription, if it's something they feel that they need in the future.
Okay, thank you very much. Brian Whittle.
Thank you, convener. Good morning to the panel. I think following on from the convener's opening questions there, I want to investigate the alternatives to medicines. What your opinion is, perhaps, that I think that the evidence we're gathering is that the default position is to medicate, and you know, what are the availability of the alternatives? Talk about social prescribing, you know, type 2 diabetes, obviously being physically active and changing, you know, your diet can be very crucial in alleviating that particular condition. And we had evidence around, you know, the best treatment for COPD might be smoking cessation, you know, or even a flu jab. So is that brought to patients enough? Do we have the capability currently to make those kind of alternative prescribing ability?
I think when it comes to social prescribing, I don't think it's embedded enough across the country in terms of what individuals know that something is available to them, and those interaction points, say, with the health service, to have a consistent approach about this. It's really good that you've got a debate this afternoon about your report on social prescribing and Age Scotland. It's certainly something which we talk about a lot, and also particularly with sports. One of the things that we have been trying to develop, and our chief executive has been sort of taking a lead on this, is sort of the proliferation of walking sports, but looking at older people being able to access that. You know, walking football took off over the last sort of 10 years. It's absolutely brilliant. There are endeavours with Netball Scotland who are now doing more walking netball. We've had discussions with the SRU recently about development of walking rugby, and lots of sports governing bodies to make the walking version of their sport available, with the aim that whatever your age, whatever your stage, wherever you live, you should have the ability to take part in a sport that you've loved throughout your whole life. Now, these are one of the things which you find when you speak to the players of these types of sports, how their health has improved, how their kind of social connections have improved, how their mental health lifts, it decreases blood pressure and lots of things therein. But because right now, if depending on where you are in the country, and again, it's a bit of a mixed bag, you might not have access to the types of things that you would want to do. So if you tell somebody, you know, you must go and lose weight, okay, that's a bit of a difficult thing for people to go and do, but you give them opportunities to go and do it in a way that they enjoy, it's much more fruitful. But I think this is the big challenge, that there's not a big enough network of this availability across Scotland, but also maybe this consistent approach of GPs themselves to know where to turn, to have almost like the equivalent of the green prescription for that type of thing.
I think we're quite lucky in Fife in that we do have quite a good referral system for a number of conditions. And across our sports centre, we run something like 100 classes a week, which are specifically health referral classes. And on the back of that, there's been a recognition that less fit groups, older people, also need streams in mainstream sports centres for the classes that they want to attend, so that they're not put off by the people in Lycra, shall we say. But it's about that lifelong getting into sport and leisure and keeping fit and keeping healthy. And I think we do it fairly well. But what we do find, I've our medication is free. In Fife at the moment, if you go to a referral class, it's not. So you've got that barrier to start with. They can only be offered in certain areas for certain times. There may be transport issues. And we also find that when the GP sends the referral list to the sports centres, about 50% of those people will take it up. Now, if we have a discussion with the instructors, we can raise that to about 70% because it addresses people's fears of the unknown, that it's not going to be for them. They've maybe never been active for a lot of their life. Maybe they feel that they can't do it, or they've been unhealthy, and there's a barrier to just getting into exercise, particularly in the first place. But I mean, you talk about diabetes treatment as well. We've got 22,000 people in Fife with diabetes at the moment, according to Diabetes UK. And we've started working on with the South East Time to Diabetes Network. And we're doing some of the counterweight stuff. Currently, that's just coming in now, but we have 240 places for the year. So there's a massive gap still between capacity and cost versus the ease with which you can go to a pharmacy and get a tablet.
What we're talking about here is probably empowering people to get to the point where they can at least partially self-manage the conditions that they're currently living with. What's your experience then of people who come to a GP surgery or come to a pharmacy expecting some kind of magic tablet to sort them out, and then they're confronted with this, perhaps the alternative, we can send you to the gym, for want of a better expression. What do you feel is the reaction generally from the general public at this point?
I think I would say maybe particularly older people or people with longer term conditions who've lived with health problems for a while, they're perfectly willing to try something. It's when it's not what you expect. You come along and it's maybe a short term condition, or you think it's a short term condition, or it's a new condition, and it's unexpected. And again, that comes down to having the time to have the conversations to say chronic pain relief is better treated. We know it's better treated if we send you to a combination of physiotherapy and other care rather than giving you a tablet. But as Adam was saying earlier, it's about having the time and the confidence and the communication skills to have those conversations properly.
There's one actually quite simple example of why this, sort of the challenges that some people might face with this. And if you use the example of someone who's maybe been prescribed medication for acid reflux, and the actual solution to that might actually be a complete change of diet. But the pain and discomfort caused by this and the relief that the medication brings sort of overrides that urge to do the preventative part. And I know that might sound kind of a simple thing, but health professionals I've been speaking to have been telling about this, that those older people they've been speaking to go, actually, no, just give me the pill. I'm not going to change my diet. It's a kind of culture thing. I'm used to this. I'm 65 or 70. This is what I've been eating my whole life, kind of thing. But now I've got this thing to do. So this what they know might be right for them, but there is that option for them. So it's very, very difficult then for the GP or whoever they're dealing with to say, no, I'm not going to give you that. You're going to have to do this other thing. They won't be in a position to do that because the GP will be trying to do the best thing for the patient. So there's a bit of kind of a give and take on both sides there. But I thought that was a really kind of neat example of where just this immediate relief from the pain and discomfort overrides anything else in terms of making it better in the long term, because there's almost that magic solution for that one condition.
Okay.
To what extent is social prescribing available, or are non-medical alternatives generally available as a preventative measure? I think you gave an example of how difficult it is to intervene when someone's already unwell, but is it used at all in your experience, and are patients keen to have that access to that as a preventative measure?
I think it's very interesting that once someone has had that first intervention with the social prescription, let's look at walking sport as an example, they see benefit. Once you've kind of been immersed in it, You've kind of lived it. You're used to it. They realise actually why I've not been doing this my whole life. You know, type of thing. It's helped me. I said decrease sort of blood pressure or improve my mental health or kind of my ability, my mobility and strength and balance. Let's say. But because there is the sort of, if you will, the mapping of all the things that are available out there are pretty disjointed, that people knowing where to turn to in the first instance is quite difficult. Just, if you indulge me slightly, for a lot of older people, we have a service at Age Scotland called Community Connecting, which is largely to target those people who have no one else in their lives, who are lonely and are looking to have more connections, whether to tackle their own loneliness or isolation. They'll just phone up our helpline, they'll have a discussion with somebody, they'll work with them for a number of weeks to look at the types of things that the person will be interested in, where it is, look at transport options and have them embedded in these groups, and it's hugely successful. And the benefit, but the challenge then is making sure the right people to know that it exists in the first place. To take that first step to make a phone call to go and do this can be a bit of a challenge, but the hundreds of people who have been positively impacted by this service will sort of tell the tale that it is a good thing. But just knowing in the first place that this is where you can go is this big challenge, and it can't be something which is just on the internet somewhere. Sure. For all those people who are not online.
Supplementary, Emma Harper.
Okay, thanks, convener. Good morning. I'm interested in, Adam, you talk about community connections, and we're talking about social prescribing. And social prescribing, that word has been around for a long time, but other people are using different language for community engagement, in isolation and loneliness, way to tackle it. We had a debate last week about singing to help with pulmonary rehabilitation, and but it also helps support tackling isolation and loneliness. So I'm wondering what language are people more comfortable using? Do they know what social prescribing is?
Adam Sturger.
I think some people will, and some people are particularly engaged in these types of debates will know what it is. But I do wonder whether you asked 10 people in the street outside what social prescribing was, whether they would know. But I think the big challenge is, because there's lots of great things happening across Scotland, there's no doubt about that, in terms of getting people more active in things, looking at alternative medicines, whether it's kind of being more connected and less lonely. It's how that becomes a bit more joined up, and having some consistency in language and leadership around that, whether it's from the government or from folks in this room and members of the Scottish Parliament and others, when they're talking about these issues, to have some common use. And I think one of these big challenges is looking at what it's called is there to do something. And actually often you can find that if you're talking about, say, tackling loneliness, it's such a negative connotation that people might not think that something applies to them, or social prescribing might sound too technical for the thing that's actually happening to them. And this group or organisation that are doing that kind of work anyway just prefer to call it something more sort of common or something more appealing. The actual solution to that, I'm not sure you could necessarily just kind of blanket, this is what we're going to call it. But I think there is so much good happening all over the place. You could probably map all those bits together and call it the same thing as you sort of allude to.
Mm-hmm.
Claire, do you want anything to add?
Yes, we've got some schemes that we're rolling out in the different localities in Fife now, and the public decision was to call them the Well. And the idea of that is that at a particular time per month you can go along, and there will be people there from the NHS, there will be people there from the Social Care Partnership, from voluntary organisations. And if you have an issue, whether it be housing or access to health, or you want to get into exercise, or you have any kind of dietary concern and the like, they can signpost you the right places to get into the system. Because I think that for a lot of this, as you say, social prescribing is a very technical, executive term, if you like, which is not commonly used. And a lot of it is getting that access and knowing where to find it in the first place. But going back to what Adam was saying about the social aspects of things, one of the things we're finding with fitness classes is we are a little bit of a victim of our own successes, because people really enjoy them. They get a real good social vibe from them. They form communities. We're having now set up social cafes alongside them so that they can spend time out with the class, because otherwise people would just not move on. And you want to get people to a level of fitness where they will then move on into more mainstream things, and that is also a gap at the moment. But in terms of interventional treatment, we do have some of our trainers will go into the likes of care homes and will do armchair exercise, and all of these things improve mobility, it improves the social groupings, and it just makes that little bit more difference. But no, we don't really think at the moment about preventative care. We're still at the stage where it's at the point of need.
Okay. Brief supplementary, George Adam.
Thank you, Convener. Good morning. I'd just like to follow on from what Adam mentioned earlier on, using your reflux example. You know, is it not the case that for a lot of GPs to deal with that as a medication is the easy option because they've got control of the situation? It's human nature. You automatically want to kind of control the situation, whereas to try and do social prescribing and push it into some other organisation and leave it to them to do it, there's a kind of, there needs to be a level of trust that the professionals need to actually trust some of these organisations to do that. And there's not a case like we have in Paisley, we have St Mirren Community Trust does the Fit Fans, and people understand that Fit Fans, it's, you know, they can go to that. I know there's variations throughout the country, you know, and would it not be easier? I don't know of many doctors that would probably prescribe someone to that, but it's probably better for a lot of people long term. It's back to your argument with the reflux again. The long term outcome is actually better than just saying, well, here's a quick fix.
I think you're absolutely right. I think what's definitely to think about is your first point about the GP will be looking for that, the immediacy. This is the challenge in front of them, and how do they fix that? And that will be in their best judgment and probably the right thing. When I was using an example of, say, acid reflux or whatever, it might be they'll be able to do that, prescribe this, but the withdrawal from not taking that medication anymore, you know, to then change of diet or whatever, is the biggest challenge actually for those that might have it. It's not so much that you've lived with the pain to begin with, then you've had the kind of the magic pill or solution, and then it's removing yourself from that and doing the right thing. But I think the sort of Fit Fans idea of that long-term solution, preventative agenda, is something which isn't talked about enough. It's not in a lot of what we deal with in sort of the health world in Scotland, looking at and investing in prevention, because you kind of, it's quite difficult to then prove its worth, because if something hasn't happened, you can't show that it's definitely that it's not happened and what the financial cost is. But every kind of study will say that there'll be a massive saving, you know, in the long term. I mean, we have seen actually an example of a GP once socially prescribing somebody a season ticket to a football club because it'd be great for them socially to do all the rest of it and everything prescribed, and because that person could afford to do so.
Adam, can I just add for the record, as a St Mirren fan, it's possibly not good for your mental health.
Well, depends. I can't say it was necessarily a Paisley GP or anything else, but I'm sure as members of my family are from Paisley and grew up there, I think they'll absolutely agree with you. But depending where that might be, it was maybe good for the social part, maybe not for the 90 minutes the game's been played, but for all the rest of it. But that's the kind of thing that has happened, and there are certainly pioneers across Scotland that will do that. But again, that kind of joint learning about what works. But the big challenge, I think we talked about later on, is this access and the cost of the social prescription. And, you know, without wanting to kind of drag them too much, there are 150,000+ pensioners in Scotland living in poverty who can't afford these types of things anyway. Free prescriptions are that kind of lifeline to them anyway, just no matter what their condition, to be able to live well and manage their conditions. So the access to how the sort of the groups and activities and the social prescription is funded somehow is also something which needs to be considered, so there's ready availability of it and it's there for the long term. And it's this big challenge that we have all the time, looking at, you know, community groups, organisations, things that are funded centrally, locally or whatever, that they are there for the long term. So once they've gone, they're very hard to replicate once more.
Thank you, Convener. Good morning to the panel. Welcome this morning. I would like to move on to a different topic, but before I do, there's a question you answered previously, Adam, to which you mentioned the fact that there are many older people who are not online, and I just want to talk in terms of access to medicines. We know that there are home delivery services are starting to be charged for, in some cases paying as much as £60 a year, but those services can be circumvented if you have access to the internet, and we know that 500,000 older people in this country don't. How much do you think that's going to be a barrier for older people accessing the medicines they need in an affordable way, considering these charges that are coming in?
Well, you took the figure right out of my mouth there. There's 500,000 over 6 in Scotland. The population of Edinburgh who are not online. There are also hundreds of thousands who have nobody else in their life to help them do so. And this all relates back to even things about kind of patients being informed about their medical needs and researching beforehand. They won't know what this is. But if you're looking at the home delivery prescription services, which again, it's best part of 60 quid a year, I think that Boot started charging last year, or sort of £5 for each prescription. Of course, there's a barrier to people. We know that there's great groups across Scotland who've been campaigning against this. Dundee Pensioners Forum is one of them, and who just think this is a bad move. And I think once that started, other pharmacies may find that they are open to doing the same thing. And the benefit of these people who may be very low income, who are remote, who have limited mobility and access to these things, might find themselves not able to afford to get the medication they need. So the danger there is not overprescription; it's kind of underuse or underprescription of the conditions that are required. And I think you can look at it and say, it's only 60 quid or £55 or £5 a go. But actually, for a lot of people, every few pounds helps. And these are some of the people with the lowest income who will have the poorest health to begin with. And I just think it's a totally retrograde move. Yes, it's a private decision, but it's something certainly the Boots and others should completely reconsider.
Is there anything you would like to add to that, Claire?
No, I would just echo what Adam's saying. It seems like it's a barrier to access. I know we have various problems in terms of waste which are related to some of the repeat prescriptions and the monitoring thereof. But at the same time, anything that stands in the way of the patient being able to access their prescription easily is a bad thing.
Thank you. So the other area I'd like to talk about is polypharmacy. And we know there are two sort of emerging agendas in health in this country which are helping to reduce prescriptions, and that is realistic medicine, but also deprescribing or having medical reviews at a regular basis so that people can assess what's actually still doing them good, what they're parked on, and the rest of it. But that doesn't seem to be universally applied, and certainly we know there are some health boards which are still spending far more than they need be on GP prescribing because they're not deprescribing, they're not having those reviews. How do we get that consistent approach to that? How do we have those discussions with older patients about the number of medications they're on, the impact it can have on their quality of life to have a review and to divest themselves of some of those drugs?
I think we can broaden out who those conversations are done with. We tend to say it's got to be the GP. We've now got GP pharmacists in position. A number of them would like to do practice medicines reviews. They're not necessarily the case across the board yet, but I think that's the way the contract they're hoping is going to go. Community pharmacies are also a good place, it's particularly to have those conversations about medicines use and whether people are taking things or not, and if so, why are they still getting them dispensed. But you have to also remember that's not necessarily the patient you'll be speaking to. So there is that communication there, is making sure that the right messages are getting to the right people.
Yeah, and there was quite a good report that our sister charity Age UK produced last year about called More Harm Than Good, and looking kind of over prescription and polypharm amongst older people. Now it's just England only, but one of the things that we would echo is this kind of almost zero tolerance approach, that inappropriate polypharmacy, and that the expectation of the patient is that those that are kind of treating them or helping them should know about this, and they should be looking at every opportunity to not prescribe. Let's look at care homes, for instance. It's sort of an average, care home residents are on over 7 different types of drugs, at each go, that on average. And you probably look at the position where how many of them will actually know that they, probably half, if not more, of those in care homes are living with dementia anyway. That are they in a position when they've been deemed as not having capacity to then question what's going on, having these proper and full discussions. And the older you get, the more medications you are on. And actual fact, the easy prescription might be to give you drug 4 to counter the side effects of, or the nausea of drug 2 or 3 for a different condition. So these things start to mount up. And I don't think this is necessarily something that GPs will particularly want to do. And I think it goes back to Mr. Adams' kind of question earlier on about kind of GPs dealing with the thing that's presented at the time, maybe the time that they've got to kind of deal with something. But I think medicine reviews are absolutely critical, like really have to be consistent. I know of people who've actually, when they've been on holiday in Canada, have undergone a private medicine review. Just, it takes a couple of hours, a full, more holistic approach to this, and they've kind of saying, well, this is what's this is the kind of medication you've got. Actually, this is what you can do to counter that, so you won't need to be on that. And I'm pretty sure for folks that are sitting there with pill boxes every morning, which never thought they'd be in a position to have such things, would love to not have to consume as many medications as they do.
And can I ask, just as a very brief follow-up, Convener, how often these medical reviews are broadened out to be more like therapy reviews rather than just pharmaceutical reviews? And I ask that because there may be cases, and I have one constituent for whom this is a problem, because she does not have access to comprehensive and adequate podiatry. She is not very stable on her feet, and she actually spends a lot of time sitting in a chair, and that has led to a range of comorbidities brought about by a sedentary lifestyle. If she'd had access to the appropriate podiatry, she'd be a lot more able, she'd be a lot more active. So do we link these two things together when we're undertaking these reviews?
I would, from the experience that we have in terms of speaking to old people broadly, I think it'd be certainly something that they'd welcome. I think the podiatry point is very interesting in terms of the change of how that's been used and funded in the past, and there'll be lots of older people who have less access to that. And if you're looking at, and I know, Ms. Clampton, you've been a big advocate of a national fall strategy anyway, that this kind of preventative agenda anyway to tackling trips, falls, and the conditions that happen there, and that could be, you know, lots of things can happen as a result of that, whether they're then stuck in hospital with the atrocious levels of delayed discharge we have, and because they can't get the right care after in their own homes. All of these things are very much linked, and the big cost to the taxpayer, but also the human cost. You know, your committee did a brilliant report last year about so I don't diverge too much, but on delayed discharge, and those people are stuck in hospital for 3 weeks longer than they need to be, can age 30 years. It's a devastating figure. These are people who will probably never be able to recover, never leave. So having that kind of wider, more broader approach, not just your medicines, but the kind of other things that can be there to support you, is absolutely vital, because for those people who will lose strength and balance and then have trips or fall, they have the more fear of having trips and falls and become more sedentary in their lifestyle because of the things that might happen. So it's them having confidence in themselves that they can kind of live independently and well in their own homes and in society, having access to podiatry and have access to physiotherapy and have access to lots of different things too, will help them live better lives. I think it's something that we'd all want as we grow older, not just to be medicated, to be able to have good lives and be active for as long as is actually possible.
Thank you.
Claire Fernie.
Just going to say, there are pockets of good ideas here and there. I mean, I can say, for instance, in Fife, we've started going into care homes with the GP and pharmacist and looking at all the residents' medications. And a lot of that, it saves in terms of waste, but it also, that de-prescribing and that consideration of what a patient is on can make a huge difference to both their safety and also their well-being, their frailty, their ability to be maybe aware of what's going on around them. It's just an improvement in their general quality of life. So we are doing starting to do some of these things and broadening out the roles of non-clinicians, shall we say, pharmacists, district nurses and the like, should make a big difference to that, but we're still early days.
Okay, thank you very much. David Torrance.
Thank you, Convener. Good morning, panel. My question is around waste of medication by patients. Do you have any insight to why patients might stockpile medicines?
One reason is fear. If you've been told that you need to take a medication, particularly longer term, and you hear about medicine shortages and the current political situation and the like, you will be concerned that you won't be able to get hold of your medication and you might overorder. In some cases, it will be about repeat prescriptions, particularly for patients who are on multiple medicines and they're not necessarily confident about what each of those medicines is for, which does happen. They will order a repeat of everything, because they're not sure whether the ones they actually take, and we know patients do order medicines that they then don't take for all sorts of reasons, but they might need them. If something changes, they might need them. So they might start taking them again, so they will reorder them. There are as many reasons patients are over-order as there are patients.
Thank you.
I was going to absolutely echo Ms. Torrance, just what Claire said there in terms of that, if you want to stockpile this kind of fear of not having it, of the unknown part of it, having a prescription or repeat prescription slip of phoning up, or now less likely to be able to phone up a GP surgery, but have to sort of somehow repeat order it online, just what you got last time. And there might be a combination of medications where, if you're looking at like maybe an example of asthma medication, where one is your sort of control, your preventer, and then one is a reliever, you're probably using your preventer till its completion, but the reliever is not. But you'll order it in a pack, so kind of the fear and the comfort of kind of not having it. But just this kind of routine that people will be in. So let's say you've been living with X number of conditions for, I don't know, 10 years, that it's just the common thing that you'll just put your prescription in your repeat prescription and have these things. And I was speaking to health professionals who have been in people's homes, and they've opened up cupboards and there are boxes upon boxes of medication because they've just had it. And they're not entirely sure why they've got it, but they've just been ordering it and not needed it at the time. So there'll be a part of it will be kind of culture, and the kind of how by not having that medicine review, they've been able to just keep repeating their order, and it's a very simple process. Thankfully, I've been able to do so if you need it. But at the same point, if they just got it and they don't use it, and it'll go out of date or whatever, and then the fear will be if they start using medication which is out of date as well, if they've kept it for many years too.
Thank you for that. The number of patients who don't turn up to collect their medicine, how could we improve this? It's sitting in the pharmacy, the order's there, and it's...
I suppose it goes back a little bit to the kind of, there might be occasions where people are just unable to physically. They might have, some examples might be that the person then gone into hospital, and then they've either, just not been able to pick it up, or they've forgotten it was there in the first place. And you're looking at the example of, say, Boots and other pharmacies that might be looking for charging service for home delivery. They're actually their inability to go and actually collect in the first instance. That would just be one example. I don't know if it's particularly, in terms of proportion of these things, how much of an impact, but there's certainly making it easy for people to kind of access their medication that have been prescribed and have been filled by a pharmacy would be a step.
I think we don't have a culture of telling the community pharmacist when people go into hospital generally. As patients, we tend to expect everybody involved in our healthcare to know what's going on, and that communication is not necessarily always there. And that means that things like compartmental aids will continue to be made up on their routine, and they may well be changed while a patient's in hospital, and that's a safety issue as well as a supply issue.
How are people disposing of their medicines, and at what level of awareness is there a return to pharmacy scheme, and how could this be improved?
I think we're doing more and more work to make people aware about returning their unused medication to pharmacy. I think awareness is definitely improving. I couldn't tell you whether it's any numbers to that, I'm afraid. What we have been doing in the last few years is we've been putting posters in pharmacies, on the back of buses, into patients' prescription bags and the like, reminding them not to order repeats if they don't need them. And also, we've got a new leaflet coming out fairly soon. One of the things is to remind people to check their bags before they leave the pharmacy. Because if you've been prescribed something that you don't want or need, once that goes out the pharmacy door, it becomes waste. And the majority of patients, I don't think, are aware of that yet. So we are making moves to try and get into the public domain with leaflets in hospitals and GP surgeries and poster campaigns and the like. But we're still not quite there.
Can I just smoke up?
Yes.
How successful has that campaign been in making awareness to the public out there?
We have reduced our waste in terms of tonnes, and I'm afraid waste is still in terms of tonnes. It's measured, and we don't have an associated cost with that because we don't look at the drugs that are actually returned and the cost of those. We've reduced that, I would say, maybe about 5% over the last, well, estimated to be about 5% over the last year, but it's a slow process.
Thank you.
That's very interesting. If you were able to give us firmer figures when you get back to base, then that would, I think, be very helpful to the committee. Thank you very much. Miles Briggs.
Thank you, Convener. And my question really follows on from David Torrance's, and good morning to the panel. Because I think one of the things we've been trying to really push within this inquiry is what's real-world experience and how can we actually look to improve for the patient that interface, not just between primary and secondary care, but community pharmacy being an important part of that. So I just wondered, in terms of your experience, and you've highlighted a couple of examples in terms of the poster campaign, what you think that could actually look like going forward. Because I know from conversations I have, especially if someone's been given advice from their GP, if they go to the pharmacist to ask questions, then that's where they'll get that information. Otherwise, they're not doing anything about that. And I just wondered, in terms of actual real world for a patient, what we could make that look like, in your opinion, especially given some of the evidence we've heard around care home settings, for example.
I think there's a few really good points in this. I think we can reflect some of this back to a lot of information being only available online for a lot of people. That there might be plentiful information that everyone in this room might be able to access or be availed of, that you can go to your pharmacy and talk about X or Y or Z, but there'll be a lot of people who won't, or they'll never be on Twitter, for instance, to see the advertising campaign for that, or necessarily interact with the NHS website. I think the poster campaigns are good. A lot of the time there can be so much noise and clutter. It might not work for people who have visual impairment, for instance. So lots of kind of these are more challenges to that, but I think this all goes back to the kind of time that the medical professionals have to talk to patients, whether it's those that are in pharmacies themselves, or the doctors or practice nurses or whoever that they're interacting with, to say these are your options now. This is what you can do, and having let's say in a pharmacy a place where somebody can have a discussion about what their medication needs is not just in the queue, with everyone else listening into what their sort of ails are. And the big challenge is not saying this couldn't happen or doesn't happen in places. It won't be consistent because people are pretty busy. There's lots of demand on the services, and it'll all go down to time, people, and money to do these things. So I think that will be a real world barrier to people being able to feel that they're able to ask or to interact or feel empowered to do so.
And as part of that, then, do you think the real block to making that happen is the patient record, and whoever the professional is not being able to actually add value when and where they come into contact with a patient or a person?
Well, I do sometimes wonder about when speaking to people, let's say they've been in hospital, for instance, and they're prescribed something, and how that doesn't fall to their GP, despite being asked about who your GP is in a hospital. And I think a lot of people would assume, if you're a patient, you'd assume that this happens. So why else would you ask what my GP is? Why will this record not be passed on? And there will be huge difficulties in matching these systems up, by virtue of the kind of the history of them. And so then the GP, knowing that the person's been described, if they've maybe not gone to the GP for that problem, and assuming that it'll be on their record, maybe not seeing the same GP twice or 3 times or 4 times that year for different things. That'll be a big challenge too. And I think if you look at how would a pharmacist be able to have access to medical records as well, the pharmacist might very well be able to talk about the medications that they're presented with, to go a bit more in depth about how they interact with all the medications, or how they interact with the person's body, or whatever conditions they're on, but not knowing what else they're on for something else or previous medical conditions. I don't know how that would really work, but I think there is a big challenge in sort of going from hospital to GP to pharmacy, and that all these things talking together. So whoever is that critical intervention point knows this person's loose history, to have a really good and informed assessment of what they're required, because after all, they are the professionals. They're the ones that you would trust to know. But the assumption that these things follow the person along is clearly something which people will be but concerned about if these things don't happen.
Yeah. Sorry, did you want to?
No, I was just going to add to that we are quite rightly very concerned about preserving patient confidentiality and patient data in respect to these systems. And some of the barriers to making these things communicate is to do with the appropriate sharing. But if you speak to people with lots of health contacts or long-term conditions, they are so fed up of having to repeat their situation to every single person every single time, because that record currently doesn't follow them. And that is a huge barrier. It's a huge barrier to safe treatment, let alone to comprehensive treatment.
I think we've heard that throughout our inquiry. Finally, I wanted to ask in terms of, and this is very much based on what's already been raised in the sense of a false strategy, and the committee's heard that the number of meds people can be taken off can reduce the number of potential falls. So in terms of your experience, do you see a good example of that, where actually that holistic approach to someone, be it that they're still at home being cared for or being that they're in a care home, is actually being put in place?
Sadly, I can't give you specific examples at the moment, but what I can say is that the strategies are being put in place, and it's partly because it's early days, we haven't been gathering the data yet, but it does seem to be making an improvement when GPs and pharmacists are considering what medications patients are on, and also in hospital. There are hospital false strategies as well, and some of that is focused around medication too.
Claire Fernie, I think, said that it would be good for patient records to be shared in order to facilitate treatment from a patient point of view. In one word, Adam Stewart, would you agree with that view?
Yes.
From a patient perspective?
Yes.
You would. Yeah, thank you very much. Brian Whittle.
I'm going to labour this point, convener. I think it's one of the most important things that seems to be a thread that runs through. We've heard a lot of evidence around, collection of data within secondary care, especially through HEPNA, is becoming much better. We've heard in primary care there's collection of data. There's a certain amount of data sits there as well that are not connected, and then we've also heard how pharmacy, the capacity that a pharmacist has to improve the situation from their perspective, but they don't get access to that data as well. And I think what you've said there is around the patient. There's two things. One, the patients are fed up repeating all the time, and two, the issues with GDPR. I suppose the question I've asked this a lot of times is around ownership of data, and the question around should the patient at the very least partially own their own data, so that would get by those kind of GDPR issues.
I would argue yes, as someone with long-term conditions and someone who is ultimately the authority on my health, then yes, that should be my data. We have, for all I'm saying that long-term people with long-term conditions don't want to have to repeat themselves. You then do also get the opposite circumstance where people in very small communities don't want to share their information with, say, the pharmacist, because the pharmacist is also the neighbour 2 doors down, for instance. So confidentiality is not just about the data management, it's also about your confidence in who holds that data and who they might share it with. I don't know what the solution is to that. I would personally like to see a national campaign where everybody is made aware of all of the health professionals that could hold their data in regard to caring for their health, and then they can opt out of that sharing.
Or opt in.
Or opt in.
Yeah.
But I think in a world where we hear about hacks every day of the year, there's a serious discussion needs to be had about patient data and who should have it and who it would benefit, as well as where it would be harmful.
Thank you very much. David Stewart.
Thank you, Convener. Good morning to the panel. Could I ask the panel what assessment they've made of the effectiveness of Pharmacy First and the extension of its eligibility?
You come to me, and as I scramble for bits of paper to think about what the answer to that is.
Perhaps I could be helpful and say that it's just had a makeover.
Yeah,
It's the
well,
old
that was
minor
what I was trying
ailment
to.
scheme.
To minor ailments. That was exactly. So it's been called sort of it's got that name, and it's Pharmacy First. And we called something else in the past, and now minor ailments. There'll be a lot of people who don't really know this is something that's available to them, and I think it does a really good and important job, particularly for those people who are going to need these types of things. Let's look at, for us, older people being like one of these big groups, people who could benefit tremendously from that. I think there's a challenge in the communication of that this is service is available, and where it's available and how they access it and lots of things, and whether it's been a digital by default example for which will work for many people. I don't think it's embedded enough across the country that brilliant service is there, that people could go in and get kind of medications without having to pay for it for conditions that they have. So it's certainly a really good thing. One of the challenges there then is, in terms of it, is it not being available, for instance, to residents in care homes, for example, that would require, pharmacists coming to be able to do the minor ailment part, but then would require kind of a GP to prescribe even some of the most basic things. So while it has lots of positives, there's certainly room for improvement in terms of it. It's obviously a great service.
To you, Convener, my follow-up question, which I think you've already predicted, is that my sense is that awareness among patients is extremely and painfully low. I think perhaps the reaction of the panel to my first question sums it up, because I think awareness perhaps among the panel isn't terribly high. But that's not been unfair to the panel. I think generally it's an excellent scheme. But I was always concerned that the old minor ailment scheme was not well known at all and had a more restricted eligibility. Eligibility is now effectively universal. Could you confirm that with Pharmacy First that care homes are definitely excluded? Because my understanding was the eligibility was to every NHS patient, but there may be some client groups that are restricted. Could you just confirm that before we move on?
I'll try and confirm definitively in writing, but my understanding is that it's not available in care homes.
Okay. And the previous scheme, as you will recall, which was excellent, still required patients to register with the pharmacist. Is your understanding the new scheme will still require some form of registration? I would assume for the accounting purposes that would be necessary. But basically, how can we ensure that patients know about this excellent scheme? Because there's no point having a fantastic utilisation of minor ailment scheme in its new marketing man guise as Pharmacy First, when basically patients don't know about it.
I think it just boils down to the kind of really simple advertising campaign at all these kind of touch points that people might have. I think it's just making sure that it's not just stuck away in our website somewhere that people go and see. I don't mean that in a kind of a Luddite type way, but looking at the groups that will benefit most from it. Yes, it'll be, of course, it's open to huge numbers of people, but those people who might be able to use that instead of going to a GP or to A&E or to minor injuries departments for things that whether there are talked about it with leaflets and pharmacy bags themselves. Do you know about this? That there is other information sessions in pharmacies themselves about, do you know that we do this thing, and talking it through with somebody, as opposed to maybe assuming here's some information, go away and read it, and people go, I'm pretty busy, I've forgotten I've left it somewhere. I think it just needs more time and attention for people to understand how it will benefit them. And it could, I think it's such a great scheme that it could see a reduction in people using the wrong health intervention point for whatever their condition is.
And it seems a really good fit with the reorganisation of primary care, does it not? That we would have a different system where you don't necessarily see a GP, you see the most appropriate health professional, but also we effectively re-dynamise the local pharmacy by using this scheme where people can register and have a much more appropriate level of intervention.
So I'll certainly agree with that, and I think it's obviously that people will be able to have quicker access to medications or whatever kind of health they need, as opposed to maybe waiting weeks to see a GP. You know, we haven't got too many details, but you know, it took me 4 weeks to see a GP in the centre of Edinburgh. At that point, the appointment was no longer necessary.
Right.
You know, so for those people who could go somewhere else for something else, that wasn't something that would have worked. But example, there could be long waits for a GP. They're already hearing examples of GPs, like it's in Arbroath today, in the Courier newspaper, I think, is closing with 6,000 patients impacted. But these are people who might have more trouble seeing that and going somewhere else. A pharmacy is such an important part and largely very convenient for them to get to, because they'll be at hearts of communities.
I was just going to add to what Adam was saying about publicity. We maybe need to not restrict publicity to medical environments. Send it out to schools, send it out to community councils. Make sure that it's a full community engagement, rather than just making the health professionals that know about it to know about it. Make sure that it's across the general public as well. I mean, I can give you an example of the previous scheme and its success. We were trying to do a study at St Andrews Medical School around urinary tract infections, and our researcher went along to the GPs to ask her prospective patients, and was told that they don't actually see them. These patients, you have to go to pharmacy to speak to the appropriate patients, or potentially, and thinking the end, they ended up in the middle ground doing it with out of hours care, because out of hours will then do is the referral system. But it was successful enough that the GPs were no longer seeing that patient group.
Which is exactly what the minor ailment scheme was, I guess, intended to achieve. George,
Thank you, Convener. Just to go on about the minor ailment scheme again, because my wife Stacey's got multiple sclerosis, so she uses that in so much as that, you know, I find it difficult that people don't know about it and use it as often as they should, because maybe it's because Stacey's never out of the pharmacy right enough, and she phones up and they know her by name and says, "That you, Stace?" But the whole point is that the idea is that you don't, as we've said previously, no GP, no A&E, you know, you're not turning up at these other places, so you're kind of moving things away from it. Because in my wife's case, Stacey had a small burn, which ended up created because of mobility issues, but it was, yes, it was something to do with MS, but the burn had to be treated. They were able to give her the dressing and kind of deal with it that way as well. And then because of her low immune system, bad cough, he was able to deal with that. Now, otherwise you'd have gone to a GP and you'd have been in the situation where Adam mentioned here in Edinburgh. But, you know, to me, it just makes sense. It's no rocket science that people would actually, with long-term conditions in particular, would use this actual scheme.
anyone want to agree with that? I think that's
No, my big thing is I just can't understand why people, it doesn't seem to be being taken up by a lot of people. Is it back to the routine where people say, I need to speak to a GP, I need to speak to a professional, as opposed, and they don't see the pharmacist as in the same level?
Claire Fernie.
There may be a level where if it's something very simple and you can get something over the counter in the supermarket, you take the medication. If you can't, then you need to see a health professional and you go to your GP. And people are not seeing the gap where it doesn't necessarily need that level of consideration.
Mm-hmm. So from a point of view, if we're agreed the minor ailment scheme really works, but that there isn't sufficient awareness of it, is there anything we should be recommending as the scheme prepares for relaunch to increase that awareness?
I think it's just a really broad kind of advertising of it and everything it can do. Great examples of how this has worked in your life, the minor ailment scheme, and people who maybe have long-term conditions will be more au fait with what's available to them and all the kind of the services as part of the minor ailment scheme that they can interact with. But there is again that idea of, and this has been a long-term, historical thing. As soon as the NHS was born, that you can kind of access it for free and go to see your GP and all these kinds of things. It's been well ingrained in people's minds for decades that they go and see their GP for these things. So it will take time. It will take time, and it'll be consistent amount of advertising over a long period of time to embed that and having people's experiences of what's worked for them, as opposed to going to a GP with really good stories to tell others, and using that as opposed to just as a prescriptive list of things you can do. thinking about how we use people to say this has really helped me. I had quicker access to the thing that helped me improve the quality of my life by using the minor ailment scheme, and it's clearly something which works. And I absolutely agree that it's something which is brilliant. It'll get people away from going to the wrong place for them.
Okay, thank you very much. Emma Harper.
Thank you, Convener. I'm interested in some issues around online prescribing or online pharmacies. Last at one of the committees, we heard evidence that the pharmacy representatives didn't seem too worried about online pharmacies affecting community pharmacies, because community pharmacies obviously provide a different service. But I mean, there's no human to human or healthcare professional to patient contact if I just order my meds online. And in front of me on this page, the medications I see are metformin and an inhaler. And if we're talking about getting folk off their type 2 diabetes meds by engaging in social prescribing, and if I just constantly online order my repeat prescriptions, then how are we reviewing them? So I'm wondering if you've got any concerns about online pharmacies.
Adam Stewart.
All right, me first. Okay. I was really hoping for an expert to lead me into this that I could agree with. I think so. There'll be some things I think which will probably be really convenient for some people to order. Let's look at maybe it's inhalers and it's routine, but at the same point you're getting an asthma check-up or some kind of intervention with the GP or practice nurse fairly regularly. I think it's a year, if not at the very, or they'll stop kind of prescribing you the things that you need. So there'll be some things which people might just find makes it much easier for them to get the medication that they need. It might actually cut down on some waste in terms of things just sitting at a pharmacy and forgetting. You can see for people's convenience whether you order your contact lenses online and other things as well, which are routine. But I think this goes back to the whole point about a medicine review. So before things are prescribed and people, however they get access to it, is who is the person that's having this medicine review to make sure that they're on the right things, or they're getting a checkup from a GP or whoever in the GP's surgery to say, like, how are these medications working for you? What are the kind of side effects, these interactions? That's a really important part before you get to the point upon which, however, somebody gets access to the medication that they need. And I think if people knew more about how beneficial the pharmacy can be to them, to have discussions as well, it might drive more people to actually go and have that face-to-face discussion. I think that's probably one of the most important parts, is the face-to-face discussion, so you feel empowered with the questions you're asking. But I'm sure there will be things for mass convenience that people will be able to order off that. But again, if people knew they could do more at a pharmacy, then they might use that service more effectively.
Claire Fernie.
I would agree with what Adam's saying. Is very much about patient convenience, I think, and I do share your concern that the conversation around that medication and whether it is suitable may not be there or may not be as comprehensive as it should be. But also in light of what we were talking about data sharing too, I don't know personally what the systems are to make sure that that would then be part of my patient record, and how that would then relate to anything else I was taking or any other condition I might have. So personally I have reservations, but I know for some people it works.
And I guess the issue with online pharmacies are supposed to be more convenient, but I mean, what would you say would be the benefits or further benefits of a community pharmacy engagement? The one thing that comes to mind is just check an inhaler technique, or do you have a spacer for your inhaler? You know, because that is a major issue that prevents people from being admitted to hospital if they're using their inhaler meds appropriately. So for me, I can see that community pharmacy absolutely benefits people to then do a check on how you're taking your meds, are you taking them properly?
It's the best place, I think, to have that education. But it's also the place to build up that relationship so that the patients may be more likely to say, well, I really don't like taking tablet X because I find it difficult to swallow. But they might not be willing to have that conversation with their GP because their GP knows best and they don't want to contradict them, and in some cases they're very aware about shortages in appointments. They don't want to bother the doctor. So yes, I would agree with you. Community pharmacy would be a great place to build up those relationships, and I think we should be promoting it.
Agree entirely.
Okay, thank you very much. Thank you very much. Can I thank both our witnesses for their evidence this morning, which is extremely helpful. And I think there was one matter I mentioned to Claire Fernie that it would be good to get feedback or more detailed feedback on the difference that the project you mentioned has made. But if there are other matters, we will write to you after this session. Thank you very much. We'll now suspend briefly and resume in 5 minutes' time. Thank you very much, and welcome back to our next panel on the supply and demand for medicines. Our second panel this morning is also going to answer questions, I think, on areas of consumption and waste. And I'm delighted to welcome to the committee Dr. David Shackles, Executive Officer for Interface and Out of Hours, the Royal College of General Practitioners Scotland. Adam Osprey, Policy and Development Pharmacist with Community Pharmacy Scotland. Welcome back, Jonathan Burton, Chair of the Scottish Pharmacy Board of the Royal Pharmaceutical Society in Scotland. Dr. Shuli Purkess, the Executive Director of Research, Medical and Innovation at the Association of the British Pharmaceutical Industry, and Graham Bryson, Director of Pharmacy at NHS Dumfries and Galloway. Welcome to you all. I know a number of you were present during our earlier evidence session with patient representatives, and you will know the areas in which we have an interest as part of this inquiry. Can I start by asking about the issue of patient adherence to prescriptions and, first of all, how aware witnesses believe that prescribers are with the adherence or otherwise of patients to medicines that they are prescribed? Who would like to kick off on that question? David Shackles.
Yes, I'll go first on that one. I think we're all aware of the difficulties with compliance, or perhaps concordance is the better term to use for patients and how they take their medications, and the variability of this. And it's beholden on GPs as the prescribers to have a conversation with patients about how they take their medications and which medications they take. And technology can enable us to have these discussions with the repeat prescribing record to be able to look back to see how well patients are either collecting their medications, but also sometimes to have conversations with our colleagues in community pharmacy who will actually alert us sometimes if medications aren't being collected. And there is a multidisciplinary team effort for this whole discussion, where community nursing colleagues might report back that there's a stockpile of medications in patients' homes to alert us where actually medications may not be taken as effectively as you might think.
And from a GP's perspective, is that something you think is normal, that you would expect to be told if there was another healthcare professional who was aware of stockpiling or of non-concordance, as you say, with prescriptions?
Yeah, I think we would be informed of that. We would expect that. And particularly now with some of the newer initiatives where we have pharmacy technicians who will actually go out and visit particularly elderly patients at home, they're actually looking for that sort of element to go on.
Okay, thank you very much. Who else would like to comment on Jonathan Burke?
Yeah, it was interesting. I really liked Claire's quote from the last session, which was something along the lines of there are as many issues as there are patients, because medicines are complex, but we as human beings are even more complex, and there's a multitude of reasons why medicines either don't get taken or don't get taken appropriately. And I agree, we need a multidisciplinary approach to this. In community pharmacy, we have a role where we're very good at spotting issues and raising issues. And as we've covered before, we probably need to be better connected IT-wise to really make sure that we share those issues back effectively and in an understandable way that our GP colleagues can deal with effectively. We also now have another layer of pharmaceutical input with pharmacists working in GP practices. But again, coming back to our original RPS submission, the time to care element to this is so important. And again, we've heard from the patient reps today about the value in building rapport, having trust between practitioner and pharmacist and patient. And it's only when really you start to develop that trust that sometimes people will open up a little bit more about the genuine reasons, maybe why they're not taking medicines or what their worries and concerns might be. And also we need to take responsibility as professionals in terms of trying to be as proactive as we possibly can in raising issues where we think that things aren't quite going right.
Okay. Shuli Purkess.
Yeah, thank you for the opportunity to come and be part of this evidence session today. As industry, we're absolutely committed to ensuring patients are prescribed the right medicine at the right time, but we realise it doesn't stop there, and I think the question of adherence is absolutely the right one. what we know is that medicines don't work in patients who don't take them, but how we empower and educate patients to adhere to their treatment is really important, and we heard from the previous witnesses, and our view is this should be treated as a public health priority. So how do we actually understand adherence and support patients to be able to make the right choices in the first place for them, and then take their medicines. I think we've heard a couple of themes already about using IT infrastructure, linking care records to make it visible to multiple care professionals what's actually going on. And actually, can we take this further and interlink real world data to help us to understand what's actually happening? You know, individual manufacturers have initiatives to support patients with information and support for individual medicines, but certainly from an ABPI perspective, we'd be really happy to be part of conversations on what we could do further, what are the opportunities to further help.
Interesting, and you talk about individual manufacturers taking initiatives on information. Are there other things that can be done in producing and developing medicines that could make patients adhering to medication easier to deliver?
Yeah, I think absolutely. And what's critical here is feedback. So for us, it's really important to understand why patients aren't taking their medicines. So if patients are taking them aren't taking them because they're having side effects, we need to know about those side effects. Clearly, the patient's individual doctor needs to know so that they can work with them to change the prescription or look at another type of treatment. But as in companies, we also need to know what's happening with the medicine, so we can look to say, is it we need to change the information we give to the medicine, or to your point, are there actually different development options we should be looking at for the future?
And your view would be that there are such opportunities there?
Yeah, I think it's yeah. So whether it's changing a tablet that maybe is 3 times a day to once a day, is it changing an injection to a tablet, or vice versa, depending on the clinical situation? Is it changing tablets to be liquid formulations? There's lots of different options there, but I think it's understanding the reasons underlying why patients are taking medicines or not taking is really important.
Okay. David Shackles.
Thanks, yes. Just to come back to some of the points that I think yourselves have been making, it's important in any health relationship of trust, that you have to trust the health professional that you're seeing. And we in the RCGP would always promote continuity and continuity of care, one of the really important things in relationship-based care. And that, of course, is one of the things that has become more difficult with the reduced numbers of GPs, the increased demand, the decrease in time that GPs can spend with their patients. And that's both in urban areas. You know, we're hearing about problems at Arbroath, we're hearing about problems in central Edinburgh of seeing your GP, but it also happens in rural areas where there may be fewer practitioners or a need to import locums to work in practice, all giving a fragmentation of care, a lack of continuity, and so potentially a breakdown in relationships and a reduction in trust with the profession. So perhaps, you know, less likelihood to take medication appropriately or to accept certain advice that's been given. And this isn't new. In John Howie, professor in Edinburgh 20 years ago, looked at patient enablement and how well doctors could encourage their patients to manage their conditions themselves and to look after themselves and to take the right treatments. The problem with pressures of time, this is becoming more and more difficult to do, and something that we need to encourage our trainees to manage. And again, with the pressure on training, introducing elements like patient enablement or motivational interviewing to help our patients is becoming squeezed out of already busy training schedules.
Okay. Emma Harper.
Thank you. Just a quick supplement. Good morning to you all. It's to pick up on what you said, Dr. Shackles, about community nurses checking if patients are stockpiling meds. Is that currently happening? Is that something that community nurses think off the top of their head to when they're visiting patients at home to check on stockpiling?
Certainly my experience, yes. You know, where there's good links between the general practice, the general practitioner and the community nurses, often where those nurses are embedded within the practice, where there's ease of discussion, where there's good multidisciplinary meetings and working, that discussion will often be had. And I think our community nursing colleagues are much more attuned to the needs of the elderly, particularly where medications comes through. And also they will provide a valuable link often with the social carers as well, who will also feed up and if they've got concerns about how their clients are taking their medications.
Okay. I've got another wee sup about smart inhalers. Miles Briggs and I have talked about smart inhalers previously. Having that kind of technology which will connect to an app in your phone to remind you to take your inhaler, which is a good compliance issue. That kind of technology is quite good. But I'm also wondering about the person that has 3 blue inhalers, one next to their bed, one in the docket of their car, and the other one in their handbag. So is that a non-compliance issue when you've got 3 blue inhalers handy in case you need them?
Often I wouldn't see that as a non-compliance issue. That's often an anxiety issue about having the right medication at the right time. And often we will advise patients to have medication handy for them in those sort of situations. The same as we'll prescribe medication for young people to have available at school if that's required. The difficulty sometimes comes in the care home situation. If we give everybody an extra supply, then there's lots and lots of it available in a care home. And in certain situations, it would be much more sensible to have central stocking that could be used. But clearly there are some issues to be overcome about that, about how it can be controlled to make sure the right patient gets the right medication, to avoid wastage of medication going out of date or not being used. And that's the same problem we very much have with just-in-case medication, particularly when it's being used in care homes, that several patients may have the same medications, often control drugs, prescribed and available, that either isn't used or only partly used and then goes out of date and is then jettisoned. And that's something that I think we're all aware of and would seek with discussions with pharmacy colleagues to try and remedy.
Graham Bryson, did you want to comment on that? No. Okay. Thank you very much. David Torrance.
Thank you, Convener, and good morning, everybody. Evidence Committee has suggested that better packaging and product design could reduce waste. To what extent do pharmaceutical companies try to minimise waste to medicines and design of their products?
Thank you. So I think it's worth thinking about the packaging in 2 ways. One is to make sure it's clear what the medicine is and to give some information with it. So that's done through a leaflet in the packaging. The other role of the packaging is to protect the medicine and make sure the quality of the medicine is the right quality, so that it's stored. So when the patient actually takes the medicine, they know that it's a quality product and it's been stored in, it's been kept in the right conditions. And so manufacturers are always thinking about those 2 things. So how do you package the medicine to make sure that it's going to be kept at the right quality, and that it will make sure, when the patient takes it, they can be assured that it is what it said, literally what it says on the packet. The packaging of the medicine is a highly regulated process, so everything we do has to be done in conjunction with the regulators, and there's a number of quality steps along the way to make sure that everything is as it should be. But manufacturers are looking to say, okay, how can we make this easy? And I think it comes back to my earlier point of having feedback. If, for example, manufacturers hear that let's say a bottle is difficult to open by the particular patients who take that medicine, they'll look to find other alternatives that still meet the right quality standards and can keep the medicine safe. But I think it goes back to understanding what are the issues behind why patients aren't taking the medicines, and how they getting their feedback or feedback from healthcare professionals on how the medicine and their packaging works in a real life setting.
David Torrance.
Is there any incentive for pharmaceutical companies to reduce waste? Because if you design better packaging, and a lot more safer packaging, it could be returned and reused, couldn't it?
So maybe if I could take that in two ways and talk about the pharmaceutical companies and wastage first, and then the reusing of the medicine second. You know, we're a long-term research-based industry that relies on results to show that we treat unmet medical needs. And we know that no medicine works if it's not taken. So having medicines prescribed and not used is not in companies' interests. And we need to know then if medicines are being prescribed but then not taken, what's actually happening. If it's side effects, we need to know about them so we can learn from that. And if it's that they're just not being taken for another reason, for example, the packaging's too difficult, again, we need to know about that, because at the end of the day, if the patients aren't taking the medicines, they're not going to get any benefit, and then doctors won't prescribe it again. So it's really important that we learn from what people's experiences are, so we can make sure that the right patients can get that right medicine for them. You know, it's not in industries or patients or NHS interest to have wastage, and you know, we want to be part of solutions looking at it. To go on to the second part of the question about reusing medicines, we know that the storage conditions for medicines are controlled up to the point they leave the pharmacy, and I think that a point was made by another member of the panel earlier on. So all the time medicine's being manufactured, being stored in the warehouse and then stored at pharmacy, we can guarantee that it's being stored in the right conditions. So if you imagine a medicine that would be stored in a fridge at a certain temperature in the fridge, you know it's been stored in the fridge and the fridge has been at the right temperature and the medicine's being kept in the right conditions. As soon as a medicine leaves the pharmacy, we don't have that control anymore. Whether it might have been stored in a fridge, but was the fridge turned on? Was it kept at the right temperature? Was the door opened lots and closed lots, so actually the temperature of the fridge didn't stay stable? We also know that it's very difficult to just see from a medicine packet whether that packet is intact and is being, you just can't tell by looking at something whether it's been stored correctly. So reusing medicines is, once they've left those controlled conditions, is very difficult because you don't know where they've been and you can't assure the quality for whichever patient takes it next.
Thanks.
There'd be a relatively small number of medicines, though, that would require to be stored in the fridge. So the question is there more that could be done in terms of packaging to secure storage? In other words, to make it, given the levels of waste you know about, is there more that could be done around the way that medicines are packaged? In the majority of cases, not requiring to be in a fridge, but simply requiring to be safely stored, that would enable more reuse of those medicines. So
all medicines have storage requirements on them, whether it's in a fridge or not, but even just packets on shelves in cupboards have storage requirements, so be it temperature requirements, be it humidity requirements, a number of different requirements. So as soon as they've left those controlled conditions of the pharmacy, we don't know where they've been. They could have been in a cupboard next to a cooker and kept, above 25 degrees because the cooker was on, or they could have been kept in a cupboard in a basement where it's really cold and gone below. You just don't know, and we don't have the records. So I think and this is all, the storage requirements are all done in conjunction with the regulators. So it's the regulators looking at the evidence of what storage requirements keep your medicine at the right quality, and then they agree those with the manufacturer. So I think it then comes back to actually how do we prevent the wastage in the first place, and how do we get information to know what's causing wastage, what are the contributing factors, and also where are we best looking and focusing our efforts? Are the particular areas where it would be best to focus, rather than necessarily just trying to solve it all? Where could we start?
Okay, thanks. Brian Whittle.
A brief supplementary. I completely understand the issue around once the medicine's left the pharmacy. You don't understand which condition it's been left in. I think so. In terms of wastage, then, Can we look at the number or the volume of a prescription? Because it seems to me that just about every prescription that I've ever had or my children ever had, we never ever seem to get to the end of that prescription before there's no need, more need for that medicine. So is there somewhere in there that especially around stockpiling of medication, that we can look at the volume of medication that's being prescribed?
So I think in terms of, we would absolutely support what people have said earlier about having a good conversation in the first place between the healthcare professional and the patient to say what's the right medicine, that gives information on gives information about how long to take the medicine for, how often to take it for. In terms of the volume that's actually dispensed, I think there are other colleagues and prescribed and dispensed, there are other colleagues who could probably answer that better than myself. But we'd absolutely also support having regular reviews so that if a prescription is written and dispensed, but actually it turns out that's not the right medicine for the patient, that the patient's got an option to go back and have that discussion.
Alice Briggs.
Thank you, Convener. We've had quite an in-depth conversation around waste, but I wanted to move it on more towards the environmental impact of medicines, and to ask the panel really where they see the impact of inappropriate disposal of medicines, and do we have any evidence around that? I think the submission we had from One Health Breakthrough Partnership suggested that around 1/5 of UK NHS carbon emissions were from pharmaceutical products within NHS Scotland. And so I just wondered, in terms of trying to address that and our carbon footprint, if you have any examples of action being taken to limit the impact on the environment.
I can maybe talk to this to a certain extent, not so much about carbon footprint, but just about the, I guess, the unintended consequences of inappropriate medicine waste disposal, i.e. it ending up in landfill or being flushed down the toilet. And I think there's obviously a message there around communicating to the public that, unfortunately there will always be an inevitable certain amount of medicines waste that's generated by households, and it is very, very appropriate. And it's important that people realise that, in the UK it's very easy just to take that back to a pharmacy. There's no need for it to end up in household waste. And rather than that just being a message that we as health professionals give across, I think that needs to be part of the wider environmental waste disposal message. We all have several bins, don't we? I'm not suggesting everybody has a medicine bin out the side of their house, but medicines need to be a part of that messaging. When I was just doing my homework about the medicines waste, there are actually quite a few sort of very scientific studies about the impact on sort of water and the environment, sort of downstream from landfill sites, for example. So if you go trawling through the literature, there is stuff there. Also, a few years back, and I forget the name of the agency, but one of the really big US environmental agencies did a big review of the impact on medication, including hormone medicines and veterinary medicines as well, on the environment around landfill sites and refuse plants, that sort of thing. So there is evidence out there, and I think there is definitely an environmental side to this. And actually, that's something that possibly we're underplaying to the public at the moment. It's not something actually I'd given an awful lot of thought to before, I have to admit, but there is a real sort of environmental impact of medicines waste, and it may actually be something that the public will positively respond to if we make that part of our message. Because there are, on a patient level, there are feelings of guilt when medicines are brought back to pharmacies. Patients can be fearful of their doctor or their pharmacist or their whatever health professional they're communicating with. Maybe they might have anxieties around that health professional knowing that they've not taken their medicines, although quite often there will be perfectly sensible, sound reasons for that. And actually we need to be having more conversations with them about that. But yeah, the environmental impact you know, it's I guess it's fair to say that it's being studied.
And
Sorry, I was just going to say we're also aware that NHS Wales have a Spring Clean campaign, which might be worth looking at to see what learnings can be taken from that.
can I ask in terms of what the requirements are currently on manufacturers, especially within packaging and leaflets? And I say this more. Recently, I'd had a conversation with a company with regards to disposable contact lenses, and actually a lot of people flush them down the toilet and put them down the sink because they've not had that conversation, not realising actually where they end up and being eaten by fish. And so I wanted to ask, what sort of situation is there today in terms of requirements for a brief conversation to actually say, don't put these down the toilet and you've got to responsibly dispose of them? Is there any requirement at the moment?
So with companies, there are international packaging standards that I was talking about earlier, and we have to adhere to them. But industry has been working to remove unnecessary packaging from products. In terms of a conversation with patients about how to dispose of the medicines when they finish them, I'm not aware of how that is happening in practice. I don't have colleagues around the table.
Yeah, so that's very much down to the professionals. You'll hear through these sessions, it is all coming round to the good quality conversations with patients. And actually, if there's a hint that these medicines won't be used, the patient should absolutely be encouraged to bring them back to the pharmacy, and that absolutely is happening, as Jonathan said. Yes, very much the messaging does go out there. As for, I could speak for space on packaging, maybe you're referencing, should there be space on packaging to say here's what to do with this if you don't use it? The regulatory requirements of what needs to be on packaging is so high, and at the same time the industry's trying to reduce the size of the packaging to the extent that actually where would that go and where would it actually grab attention is another question. So it's got to come back for me to the professional and patient conversation.
Yeah, again, I mean, these conversations are starting to become more commonplace, and I think they started off with the more obvious. Our diabetic patients who are self-injecting obviously need to return sharps and other disposable stuff to their pharmacist. But with the advent of other injectables, Fragmin and other such medications, we're getting increased conversations. Our patients who take regular inhalers like to return those. There's various schemes for that, for returning inhalers. That's quite appropriate. But I agree that needs to then to be rolled out to other unused medication, so that it can be seen not just as medications that may be reused, which is not necessarily appropriate at the moment, but because of its environmental impact. I think patients are becoming much more receptive to that, but it needs to be that continued conversation, both from our profession, but also at the point where those medications are dispensed, to have more indication that they can be returned to that point as well.
And I think looking at sustainability issues such as this is a key work stream for us as ABPI this year, so we'd be happy to continue conversations as they develop.
That's very helpful. Acknowledging Adam Osprey's point about there isn't room to put everything on the packaging, would it encourage patients to return medicines if the cost of the medicine was in the packaging?
I've probably got a very visceral personal reaction to that. With displaying the price, there's a number of things you have to think about. So, one, very simply, what if the price in the medicine is actually less than expected? What sort of behaviour does that drive? You'll have heard through these sessions that actually generic prescribing makes up the vast bulk of prescribing, and therefore the cost of some of these medicines actually per packet is relatively low. There's also a part about stigmatisation and shame around patients and how that would make them feel with that price displayed on those medications. And you can absolutely bet from personal experience that it's the people who would see that and feel shame and wouldn't take the medication is exactly the people who would need it. So is it somebody who chooses to save the NHS £5 not to take the medicine that's going to prevent them from having a stroke in a number of years? The moment that happens, you've absolutely failed in that initiative. So I've personally, I feel very strongly about that. That's not the way to go. It's got about the preventative action, about having the conversation, getting people to value medicines, not just see the price, because those are two entirely different things.
Okay, fair point. Miles, are you okay? David Stewart.
Thank you, Convener. Good morning to the panel. How can we better control medicines waste in the hospital settings?
Good morning, panel. As you probably have heard from some previous sessions, the difference that we have in the hospital setting is the fact that we've got more of a closed-loop supply system. So while we bring the medicines into pharmacy, they are then either issued up to wards or given to patients on discharge. When they are issued up onto wards, we have an assurance in line with the manufacturer's regulations that we are adhering to the temperature and storage requirements. That then gives us an opportunity that where those medicines aren't used, that we can recycle and reuse them back within the system. But it's important to note that no system is waste-free, as one of my colleagues alluded to earlier on in terms of just-in-case medications. Within the hospital, there is a list of medicines known as the rarely used medicines, and these are medicines we're obliged to keep for particular clinical situations, and if these situations don't arise, unfortunately, some of these medications can go out of stock. However, they are a small amount. Another situation where we could have waste in hospital is where an unusual medicine is prescribed for a patient in a particular clinical indication that's not held routinely as stock. And that patient's clinical situation may change, that may require that medication to be stopped, and therefore there's a low likelihood that we may use that medication again. However, again, to mitigate that, we wouldn't normally keep large supplies of this medication within the hospital setting. And I suppose a third one, as I say, no system is perfect, and unfortunately there can be incidents such as a fridge failure, etc., either within a pharmacy or in a clinical ward situation that may mean that we are out with the regulations for retaining that medication to be used in patients. Within a pharmacy sense, we can run a pretty tight ship within a hospital pharmacy department. Our probable biggest challenge is once the medication leaves the pharmacy and is then taken up to the ward area. As you'll appreciate, the hospitals within NHS Scotland are running pretty hot at the moment, and that means that we see a quick patient flow running through the various departments, and as much as we can put systems in place to try to make sure that that medicine that is issued to one patient in one setting follows the patient to the next setting, there can often be situations where that's not possible.
And then, through your Convener, in your experience, are the targets for medicines waste in hospitals being met both within your board and in other boards across Scotland?
So in my time in NHS Dumfries and Galloway, which is relatively short, we've not had to contact Scottish Government around about any sort of significant medication loss, which we have at a £50,000 level. And generally across Scotland, it's a recognised benchmark to make sure there's minimum waste.
Yeah, because I think from previous inquiries we've had or previous evidence sessions, the targets, the KPI is 0.4%, and that's been met as the evidence we've had previously. Is that? Would you confirm that?
I think that's fair.
Okay. And my final question to you, Convener, could the panel provide any examples of best practice in this area, both in Scotland or indeed other countries across the globe that we can usefully use in this inquiry?
Are we talking out with secondary care now, just across the board? Yeah. Okay. So, I mean, I think it's not an understatement to say that pharmacy practice in Scotland is the envy of the other home countries, and there's a number of reasons for that. Looking at community practice, it's an evolutionary process, but we do have what was formerly known as the Chronic Medication Service, which is now known as Medicines Care and Review. We have an online system called the Pharmacy Care Record, where we can populate the work that we do in community pharmacy practice around speaking to patients about their new and, importantly, their ongoing medicines. And the foundation of that is a basic sort of just how are you getting on with things type check. You know, do you know what you're taking things for? Can you take your medicines properly? And that's been embedded for quite a few years now, and I think it's fair to say that we need to do more work to sort of bring that on and make sure that we're absolutely consistent with it and that patients are getting the help and the support that they need with their medicines. But that is fairly unique. And I think if you look at the way that our GP practice workforce has fallen into place over the last couple of years and the impact that they've made in many, many GP practices, also in practices that were struggling from a sort of GP manpower point of view. I think there's some fantastic examples of how we've managed to keep medicine safety, at the forefront of what we're doing there.
Shirley Perkis and then David Shackles.
In terms of other things to look out for adherence, there's an NHS Wales campaign called Your Medicines, Your Health, a public education campaign, and the general message of it is take them, take your medicines if you can and tell us if you can't. So that might be something to look at.
David Shackles.
Thanks. I'd just like to go back to your point about medicines waste in hospitals. I've an interest in medicine at the interface between primary and secondary care, and that's often an area where waste can occur at times when our patients go into hospital on a certain medication regime for very reasonable reasons. Certain medications may be withheld, either because of renal problems or whatever. Those medications may actually be taken away from the patient, but they're to be restarted when the patient's discharged, but a new supply is required because it's taken off and lost within the hospital. And that can create a considerable amount of waste, and we need to have better discussions about that between primary and secondary care. I would certainly agree with my colleague that one of the most influential and important things that's happened over the last few years is embedding pharmacies within general practice, so that medicines reconciliation, looking at what medications patients are on when they're discharged from hospital or even before they go into hospital, is absolutely critical and very useful. And another really important thing to emphasise is the communication with the patient at hospital discharge. That actually where hospitals provide the patient and or the carer a list of the medications that this patient is taking on discharge and the reason why they're taking the patient is really very useful. Along with the possibility that often the discharge letter is written to the patient to inform them of what went on in hospital so that they can better understand what medications they were on. And I think initiatives like that are really to be commended. They're not universal, but they are becoming commoner and are very much applauded by the Academy of Royal Colleges in Scotland.
And what needs to be done to make them more general?
For my own health board, one of the breaks to it is actually the cost of communication, actually the cost of sending out additional letters. They can see that can be a barrier to that. But when it's seen as good practice, clinicians like to use it. Empowering clinicians to do it, say yes, that's what we should be doing, is one of the things. So making it commonplace, making it best practice, celebrating that, I think, is the easiest thing to do. Because when we can see the benefits to the patient and to the system, then people will start to do it. And the cost actually is then absorbed in the benefits, in the lack of waste.
Thank you. You've got a couple of brief supplementaries. First, Emma Harper and then Alice, please.
Okay, thank you, Convener. Just a quick question for Graham. You said that £50,000 is what the loss would be for meds wasted. How does that compare with the total meds expenditure then?
Well, that obviously depends on the individual board. And in terms of, I think the definition of £50,000 as a trigger to advise that there's been a significant incident would be the way to consider that number, as opposed to a percentage of an overall spend in medicines in the acute.
Okay. And I also had another wee quick question about elective patients are encouraged to bring their own meds into hospital. Is that something that's monitored percentage-wise? Are patients bringing their own meds into hospital so that we can make sure that we're using their meds that are already prescribed and not have to reissue meds for folk that come in?
In that particular way, I think it would be more an ad hoc consideration that if an individual hospital felt that message wasn't coming along strongly enough, that there may have to be a bit more conversation with patients, either at pre-assessment or as part of the information that they get given before they come into hospital.
Okay, thanks.
Thank you very much. Miles Briggs.
Thank you. It was more a follow-up to Dr. Shackle's question, because I know through the work I do on as co-chairing the cross-party group on cancer, cancer patients are now entitled to a patient treatment summary. And I was just wondering, in terms of your experience, what value that adds to any further conversations which take place, and whether or not, I know you've outlined the admin cost of actually delivering that for every single patient, but whether or not that could be simplified to actually give people the information they need before they leave. Brian Whittle and I visited Crosshouse Hospital quite recently, and the embedded pharmacy they have in the A&E unit there were offering a similar sort of service. So I just wondered, in terms of that idea across all patient groups, where you're seeing that developed.
David Sharp and then Adam Osprey.
Yeah, I think there's considerable value in that. Patients then can then read, their carer can read and absorb what has happened, and that then can then enhance the conversation that they can then have with both their GP or any other health professional, be it the district nurse at a home visit, Macmillan nurse, or the community pharmacy. I think there's great value to be had in that. And that is actually also being mirrored in other areas, such as the House of Care model for chronic disease management, where patients may attend for their investigations, be sent a summary of the investigations. Then they come to the practice nurse and have a discussion about the results, so they can discuss actually what's important to them. Is it their HbA1c for diabetic control, or is it their weight? What particularly do they want to target and look at? So giving the patients information before they actually have that shortish professional discussion allows them to work out what's important to them and to best target and make choices for themselves. So I think it's a very useful intervention.
Yeah, I think across all patient groups, my colleague Jonathan mentioned earlier the evolution of the Medicines Care and Review service in community pharmacy, and that's absolutely a goal of that service, and even in its current form just now, that patients are given over time a treatment summary, and they're able to gain access to or have print-offs of any care issues that are identified, actioned, resolved. And that also is shared at the end of treatment. The patient's essentially discharged into the care of the community pharmacist for whatever medication or that they're given on a long-term serial prescription, and then information about what's happened during that 6 months or a year that the prescription lasted for is then communicated back to the patient's GP as well. So you heard earlier on about issues about sharing information. That's probably one area where it is working well. There's a lot more to be done to make it more commonplace, but that absolutely helps in keeping patients as active participants in their own care.
Thank you very much. And one of the things we've heard previously is that discharge from hospital can be delayed in part by difficulty in getting the necessary medicines signed out in time for a patient to leave on the same day that they should. Is there anything that can be done from a hospital pharmacy point of view to focus on and address that issue?
Repeat anything that you've heard from previous committees on that, but I will allude to a piece of work that my colleague Gail Caldwell from NHS Greater Glasgow and Clyde mentioned about how within the west of Scotland we're looking at the possibility of alternative discharge medication supply routes, but that requires some significant scoping and some additional work that we would need to do before we could make any sort of firm decision on that at this stage.
Understand that point. What is it, can you tell us, that is being looked at as potentially offering an alternative supply route?
Give you an example of where we are within NHS Dumfries and Galloway, particularly out in the west of the region, in the Stranraer area, where we have a very strong community pharmacy network associated next to our Galloway Community Hospital. And at the moment, we have a situation where our community pharmacies are currently providing the discharge medication, not on a 100% basis, but where it's appropriate that we can do that. And our next hope is to use our electronic immediate discharge letter to try to facilitate that moving forward. As I say, this is very preliminary, and is very much at the scoping stage at the moment.
I think that's something the committee will certainly find interesting to hear more about as it develops. Brian Whittle.
Yeah, I think the committee's had quite a lot of evidence around the deployment of the HEPNA system within secondary care, and the potential that has to improve the supply and prescription of drugs within that setting. So I know it's been deployed in several sort of boards, Dumfries and Galloway being one of them, so you're back in the hot seat again, Mr Bryson. So I wonder maybe if you could maybe give us a wee insight into how the HEPMA system is working within Dumfries and Galloway.
Yeah, sure. I think to start off, it's probably worthwhile saying that we were in the early implementer phase in terms of this, along with a couple of other health boards. We've had HEPMA installed within NHS Dumfries and Galloway Royal Infirmary for a period of between 4 and 5 years. It was installed a couple of years before we moved to the new build out on the outskirts of Dumfries. I think it's important for the committee to see HEPMA, the Hospital Electronic Prescribing and Medicines Administration System, in a sort of two-phase process. The first phase clearly is round about the move from the old traditional Cardex model to an electronic Cardex or record for medicines and for prescribing. And the second stage is about how we can use that technology and the data that is generated from that to try to improve the safe and effective use of medicines within our hospitals. Within Dumfries and Galloway, we are probably at the stage, it's fair to say, that we feel we have secured the changeover from the old system into the new system. Potentially interrupted by our move to the new hospital, which again is a hugely significant cultural issue that we have to see through. But now we're at the stage that we are opening the door on the benefits that we can get from looking at the data. At the moment, having spoken to medical and nursing colleagues as well as pharmacy colleagues, from our medicines administration point of view, HEPMA provides the advantages that it's a more clear, legible record that therefore reduces the risk of a medication administration error. Interestingly, within the specificity of the system, it also means that from a nursing point of view, that only the medicines that are able to be dispensed at that particular time are actually dispensed, and therefore again reducing further risk of administration errors. But nurses also comment that one of the advantages is that they're no longer having to route about looking for Cardexes because they're working off a laptop that is in the patient rooms. And I don't think we can underestimate, in terms of we hear from colleagues talking about releasing time to care, and again these be marginal gains in terms of minutes that can be saved are allowed to be put back into patient care. From a prescriber point of view, the system that we have now in Dumfries and Galloway means that we have to have a complete prescription record, right down to the nuances of formulation, dosage and frequency, which means that when a prescriber is making the decision that a patient is to get a medicine, they are required to give a 100% complete level of detail. And often in a busy environment, a small piece of detail can be missing. And as a result, that requires other members of the MDT, such as nursing or pharmacy, to go back to that prescriber and seek a wee bit of clarification. So the fact that we have a default situation that we have to provide all the information at point of prescribing, that reduces waste of people's time. I'd also like to mention, in terms of Dumfries and Galloway, I alluded earlier on to the Galloway Community Hospital, and the HEPMA system has allowed us to introduce what we would call remote prescribing, and we have used that within the renal dialysis team. So we've got renal consultants able to prescribe for patients in the DGRI, and while patients are being treated 75 miles away in Stranraer. So that's a very effective use of that technology to make effective use of people's time. From a pharmacy point of view, we've talked a lot about the transcription errors and the ability to reduce that and reduce the risk. We are at that stage that we're starting to look at the data that is generated from HEPMA, and probably the best example I could give the committee at this stage would be round about our daily antimicrobial reports that we generate to take part in the microbial team's ward rounds with orthopaedics and surgical teams to make sure that we are adhering to the good principles of antimicrobial stewardship, which I'm sure you're aware is a very high public health issue within the NHS in Scotland. So that's been our sort of journey so far. Now, just like to wrap up by sort of saying where we see ourselves going next, and in terms of what we can do in terms of HEPMA. So we've recently just introduced remote pharmaceutical care to supplement the remote prescribing within the Galloway Community Hospital, again saving practitioner time and making best use of our resources. For a couple of years now, we've been routinely sending the electronic immediate discharge letter to community pharmacies for patients who have got high pharmaceutical care needs, and that's particularly round about medication support services that we have to provide. We've recently just completed as what we believe to be the first outpatient prescribing pilot in the NHS in Scotland, that in theory we could have done without HEPMA, but the HEPMA expertise and the integration and collaboration with colleagues within IT and information governance has allowed us to have those networks within the board to make that happen. Moving on and moving where we go next, I think I alluded to earlier on about the opportunity that we have to try to use the electronic IDL to support an alternative method of prescribing medication at discharge. For us as well, where we feel we really want to go is to be able to use the data to help inform prescribing decisions and medicines usage figures within the hospital.
Much. Thank you for that. That's what I call an insight. So you were prepared for that. So thanks for that. But I think what we're getting there is a real feeling of that HEPMA is a big step forward in terms of the data collection and how we use that data. So can I ask, how easy is it for you to, or are you, Davis and Galloway, sharing that sort of good practice and that learning with other trusts and what the barriers to doing that?
So, I mean, NHS Ayrshire we're the vanguard innovators in terms of this. So up until recently, the learning has been shared on a very iterative sort of approach. So when Dumfries and Galloway looked at this, there was a lot of conversations had with colleagues within Ayrshire, and as Forth Valley start to roll out, they come into that conversation, and then as NHS Lanarkshire we moved out to do the national implementation pilot, that learning was there, and of course that learning was supplemented by a report that Healthcare Improvement Scotland and NHS Forth Valley wrote about learning points from the rapid rollout. That is done at the moment through a specialist network of HEPMA pharmacists and pharmacy technicians and IT individuals. And because pharmacy is quite a small family within the NHS in Scotland, we do tend to know each other, and that does help facilitate conversations as we go. As the national implementation programme itself rolls out, I think we're probably going to see, quite rightly, as I said, about the two phases. You know, the next few years are going to be very much about securing that implementation, and our experience has been that as with all IT solutions, there can be a lot of expectation put on them, and there's a fair bit of expectation management about what they can't do as well as what they can do. So there is a learning period that goes through there. But as that implementation phase ends and we start to look at where we go next with the data, we feel as a profession and working with colleagues in IT and data analytics, that is where our strength will come moving forward.
Can I ask a very small something? It would be remiss of me not to raise this, as I think Jonathan Burton alluded to it, as did David Shackles. The data that's been gathered around HEPMA and the patient data around HEPMA, how can that be utilised through IT into primary care and through into sort of community pharmacy?
So I think the important thing to note for the committee at this point is that HEPMA is, and I'll say it again, hospital electronic prescribing and medicines administration. It's actually not designed as a data analytical tool. So I am no data analyst or IT expert, but from my understanding, what we have to do with the data that is generated from HEPMA is we require to apply some analytical additional software onto that, so that we can actually take essentially raw data and put it into a format that allows practitioners, whether it's medical nursing or pharmacy or others, to be able to interpret. The data itself is very powerful, but unless we apply quality improvement methodology and apply it in a multidisciplinary setting, it will be nothing more than data that we can't make most of.
Thank you.
Jonathan Burton.
Yeah, just to come in on the point about the information sharing out into primary care. I work in NHS Forth Valley, and in community pharmacy we've been the beneficiary of a lot of the hard work that's been put into HEPMA at Forth Valley Royal. And what that means in practice is for the last probably 3 or 4 years now, with patient consent, when a patient is admitted to hospital, if they have a regular community pharmacy, then that community pharmacy does receive an admissions note in terms of we know that that patient is now in the hospital. And from a medicines waste point of view, that can be really valuable information. And also from a patient safety point of view, it's really valuable information. Quite often that patient may be an elderly patient on several medicines who possibly receives home delivery service from the pharmacy, and without that note we would not know what was going on and where they were. And again, just like in some of the other health boards, we receive the immediate discharge letters. Initially they came via email, but in Forth Valley we've worked to the point where our pharmacy care record, which I alluded to earlier, which is the online tool that we use for our community pharmacy-based medication reviews, also supports stop smoking service, gluten-free service, SBAR communications for acute conditions. But what it also does is we now have a hospital tab in Forth Valley, and that's where we access all our admissions and discharge information. So you know, you could argue it's still a little on the clunky side, but actually it is genuinely useful in practice, because we've, you know, especially that discharge information, because quite often, you know, the community pharmacies and the GP practices really have to work hard to make sure that that patient is transitioned safely back into the community so that medicines reconciliation happens. A lot of that MedsRec work is done by GP practice pharmacists. There have also been pilots, and there are situations where community pharmacies naturally do a lot of that work, either formally or just part of our day-to-day as well.
Shackles.
I would agree with a lot of what Jonathan has said there. I work in NHS Tayside, and we are at the very early stages of discussing HEPMA in secondary care, and we in GP very much look forward to that happening, both of the medicines reconciliation from the immediate discharge letters, but also to try and improve some of the outpatient communication. Our secondary care colleagues at the moment are using technology that they don't feel is fit for purpose in communicating with us, and often will still revert to communication, their medication changes in the letter to the GP that may come out sometime later, that will go to the general practitioner and not to the practice pharmacist, who may be best placed to make the prescribing changes that are required. So it has an effect not just on the medicines management, but on the workforce management within the practice as well. And so where there are good technological solutions that are coming out in variable ways, we think that the work needs to be done to make it a level playing field across the country, to get everybody up to the same level technologically.
Okay, thank you very much. Emma Harper.
Thank you, Convener. As a previous nurse and employee of NHS in Dumfries and Galloway, I can absolutely identify with the searching for Cardexes. So I was part of the HEPMA implementation when it first rolled out. We took evidence from a previous witness that said that writing a prescription by hand took him 30 seconds. So I'm interested to know, once somebody's trained in HEPMA, how long does it take to input the prescription? I completely understand that safety is an issue, and I've had to query many Cardexes and handwriting previously as well. So I'm assuming HEPMA, once it's up and running, once you're trained, it's actually quite easy to put a prescription in.
Yes, that's correct. Yes, it is. But there is obviously that transitional period, as you'll remember, in terms of that sort of cultural change, in terms of understanding that the prescribing system is slightly different to what you would have just normally been used to. But I think as we see that becoming more and more across Scotland, we'll see that consistency of approach. And at that point, we'll then be bringing through our pharmacists, nurses and medical colleagues to that normal standard level. And I think it's important, you know, for us to acknowledge that the HEPMA system is the first critical step that we need to do to make sure that we improve the safe and cost-effective use of medicines within hospital.
Okay, thanks.
Thank you very much. George.
Thank you, Convener. Good morning. As you can probably see in front of me, I'm the only MSP that's completely digital here with all my, no paper here to be seen apart from my pad in case I need it. And it's on technology I'd like to talk about because it's all about the trust in that technology to take things forward. Now, we've had claims from individuals and organisations and companies saying that the medicines budgets can be transformed by the use of technology and automation. Now, there's been, they say it would improve nurse efficiency and free up their time, reduce medication errors and reduce wastage in hospitals and at home by improving stock control and driving things forward. Now, in your individual kind of spheres with regards to this, do you actually agree that the benefits of automation in dispensing process in the Scottish NHS and at the pharmaceutical industry?
It's probably worth delving into what we mean when we say automation. So the emerging evidence, and it is very young evidence, would suggest that using robots, if you will, for dispensing, certainly in a community sense, requires enormous scale to deliver efficiency. What may be another way of looking at it is, so in pharmacy, generally a medicine makes its way through the pharmacy and must undergo a check for accuracy and a check for clinical appropriateness. The accuracy check does not have to be done by a pharmacist, but traditionally is. There are a number of emerging technologies across the country, and several pharmacies are now picking up this technology whereby they can utilise appropriately trained staff and technology together to actually get some really good gains in time for the pharmacist by performing that accuracy check using barcode scanning technology to make sure that what's on the prescription matches what's on the label, and that label's actually applied to the right medicine, because all medicine packs have barcodes now as well. So there is huge potential, and that all that time that's saved can then be put into actual patient conversations as well. So there is, I would agree, there's huge potential there.
David Shackles.
I think you ask a good question, and referring back to actually the previous panel where we were talking about medications going onto a patient's repeat prescription record, that once it's on there, it tends to stay on there without being sense checked and reviewed and taken off. So things can get very sticky into the repeats, whether a patient needs it or not, and that means that we do need to have good systems to make sure that even in the interface between the hospital and primary care, that we look to check that things are still appropriate and are still required, rather than just going through electronically, because they can go through electronically very easily.
Just to follow on, one of the particular companies that gave us was Omnicell, gave us examples. I think they're already involved in Scotland. Now, I know they've already got a dog in this race anyway because they're trying to sell tech to the NHS. But some of the figures they've got here is that, the technology reduced hospital medicine supply stock by up to 40%, save hospital medicine supplies consumption by 5 to 15%, reduce round times in care homes by up to 75%, freeing up staff to deliver more care. Now, these are all very impressive figures that they're doing, and they say they can do it in a various way of, almost sounds like when you're talking about robots earlier on, Adam, it's they talk about for pharmacy, this includes robotics, automated dispensing cabinets, intelligent trolleys. Now, this all makes sense to me. I know there'll be a cost involved to implement most of this, but do you think we're in a place where we could get to actually doing these claims? Are these figures actually, do you recognise these figures? Could that actually make that difference? And also, are we in a place where you believe we could trust the technology to actually deliver all that? Because when you look at it, if I use the MSP's example, I'm the only one that's sitting here with digital and trusting the technology. Trust is a big thing in technology. So, are we in a place where we could do that?
Healthcare is a complex system, which you'll probably have gathered an appreciation of over your time on the committee. I think the trust is emerging in these things. I've certainly been to demonstrations of robots, and they're very impressive in the level of accuracy. There will always be humans around about that technology, however, so a computer is only as intelligent as what somebody tells it to do. So that just needs to be borne in mind, and I would refer back to what my colleague Graham was saying around about culture change as well. So just throwing a piece of technology into a system doesn't bring you efficiencies automatically. It needs very carefully managed into place. So there isn't probably a black and white yes or no answer as to should we adopt these technologies. What we probably need to do is spend some time very carefully researching the best ways and where each individual piece of technology fits. So a robot for hospital may actually deliver some great efficiencies that just wouldn't work in community pharmacy, because you're actually talking about two fundamentally different business models and two different ways that patients access those services. So there's no yes or no.
Graham Bratton.
I apologise if the committee is already aware of this, but it would be remiss of me not to highlight that as part of the Achieving Excellence in Pharmaceutical Care strategy from Chief Pharmaceutical Officer, SG commissioned a review of robotics within community pharmacy. And I'm unaware if the particular company is involved in that. I don't know that level of detail, but we're expecting to see the report of that back in mid this year to see how that has been.
Alec Cole-Hampton.
Thank you, Convener. Good morning to the panel. We've learned a lot in our inquiry about the confluence of a shallow dive into knowledge that a lot of patients have through the internet and Googling their symptoms and the rest of it, and identifying treatment pathways, including drugs of choice that they might like to be prescribed, but their consultants and GPs may have other ideas. Similarly, pharma companies have got better at marketing as well, using platforms like social media to do so. So I've got a couple of questions about that. How common is it for patients to want to access medicines when they're not necessary for those conditions? And is there a way in which we can inhibit that or address that head on?
So I can probably talk from my experience of community pharmacy, and it is very common. So there are two ways where a patient will try and access medicine, either by coming to you with the symptoms that need assessed, or by coming to you with a direct product request, generally for not prescription medications, because they'll realise they need to go through their GP. And the Scottish Government's actually put a lot of investment into the community pharmacy network in terms of education and training over the last 3 years to enable and empower community pharmacy teams, the whole teams, to open up those direct product requests into a consultation. And actually that's the premise. I'm going to try and sneak in here the bit about NHS Pharmacy First, which is the replacement for the minor ailments service. That whole service, and we need to be very careful about how we talked earlier on about promoting that service. That's all fair and well. We need to be careful about the language we use when we're doing that. It's actually a consultation service where we encourage people to bring their symptoms to us. I think that would actually help to change that behaviour of self-selecting when actually what you need is the assessment of symptoms. And we've even gone to the effort of working with our Scottish Government colleagues to even structure the funding so that the outcome of those consultations from NHS Pharmacy First service doesn't matter if it's only advice, if something is actually prescribed, or actually if the person's referred on, it doesn't matter. There's no incentive to provide, and that will help. Again, there was a theme running through earlier on about patient expectations, and we need to set this up for success in helping people to understand that you shouldn't expect to go access the service and necessarily walk away with anything, and that's okay.
I think it's also important to remember that pharmaceutical company activities are governed by the Human Medicines Act in the UK, and there's a self-regulation code, and for prescription medicines, companies are not allowed to promote to patients. So any promotion that companies do has to be to healthcare professionals, and there are very strict quality standards to make sure that what companies say is fair and balanced, and describes not only the benefits but potential risks of the product, so that then that's helping that conversation between the healthcare professional and patient to make sure that they've got the right information there.
David Chuckles.
Thank you. Yes, I think that's becoming commoner discussions. Patients are increasingly well informed, often from the internet. They will often say, why am I on this medication rather than another one? And that is, beholden on us to have that discussion to try and explain it. We do have discussions about local formularies, why certain medications are prescribed, why medications are not prescribed, and also are increasingly referring patients back to decisions from the Scottish Medicines Consortium about why certain medications aren't available, but also recognising that medications are becoming available that are newer, more novel, and often actually referring patients back to specialists for consideration of those medications where it's appropriate. But yes, the discussions are becoming much more commonplace, but we're needing to have more in-depth consultations with patients about it, and using more complex decision aids to try and explain that to patients in ways that they can understand, using information like Kate's plots, where you will show it with the, you might be aware of the 100 smiley faces type diagrams, to try and help patients to understand why this medication might be appropriate for them or why it's not. But of course, all of these discussions take increasing time from what we're trying to do. We've already heard about trying to maintain our access. So we feel we need more time to have these useful discussions that may actually give better care for patients.
Final question, if I may, Convener. Do you believe, as a panel, that the pharmaceutical industry is driving up consumer demand? Are you finding, do you believe that patients are becoming more informed as to pharmaceutical interventions that might be available? They may be asking for specific branded products when a generic is available at much lower cost, and their expectations need to be challenged in that regard.
I think that the controls that my colleague has described around about the pharmaceutical industry's activities and direct-to-patient marketing are actually very robust in this country. Again, talking about over-the-counter medications, and when people come in to have their symptoms assessed or looking specifically for a product, we've absolutely designed this new NHS Pharmacy First service so that there will be an approved list of products that are generic and will be prescribed generically and supplied generically. If the patient is really, really adamant that they would prefer a branded product, that's absolutely fine. They'll have the option to purchase that, and they'll still get the benefit of the advice from the service. And that'll just be, again, a behavioural, cultural thing that we'll have to learn as we go along to get people used to that message that actually this option for you is effective, is safe, and we've got a lot of experience of using it.
I think an informed patient is an engaged patient, and I think as a profession, pharmacy and pharmacy technicians would thoroughly welcome more conversations with patients to have these realistic medication conversations, as Adam alludes to there, because if we really are serious about making and improving things, it's clearly got to be done in collaboration with our patients.
Yeah, increasingly when I'm talking to patients, and the pharmacy where I work, we have a really active sort of walk-in service which covers minor ailments, pharmacy first, and an independent prescriber led walk-in clinic. One of the things I increasingly hear back from patients is, oh yeah, that's kind of what I read on Google. So patients are coming to us better and better informed, and sometimes they will have hit the nail on the head for their symptoms or their medicine requests. Sometimes they're a little bit off the mark. That's our job, to work with them to make sure that the treatment choices that we make are safe for them. But I think we need to appreciate, and I would agree, I think the systems we have in place where we don't have direct-to-consumer marketing are very robust, and actually I feel that makes our life in practice generally a lot easier. It's not always the case with some over-the-counter medications, and I think we need to think carefully about the way that some substances that are liable to misuse are marketed to the public. I think that needs more attention. It's maybe a conversation for another day, but I think that's something that needs noting. But certainly, yeah, we're seeing better informed patients. The world and information's an open place now, so we need to tailor our services around that, and we need to. I think we need to be quite grateful, actually, when patients come to us when they've done a little bit of their own research, because we do need to be banging the drum for self-care. and for people to be, you know, to have a self-care plan. I think we've talked about this at previous sessions in terms of educating people from a very early age, i.e. school age, about the basics of looking after yourself and when to seek help, so that we end up with GPs who are doing absolutely what they should be doing, i.e. they're the experts in undifferentiated diagnoses and looking after people long term, that we've got community pharmacists who are seeing the right types of patients for our Pharmacy First service, but that we've got a lot of patients who are able to look after the basics themselves.
And David Shackles.
I absolutely concur with that sentiment. We do regularly get letters from patients asking why they're not being given a certain branded medication, and more often than not that will be followed up by a letter from their MSP asking why they're not being given a branded medication. We then have to spend quite a lot of time writing back indicating that there may be no clinical indication for giving a branded medication over a generic medication, no actual allergy going on. That takes time. Occasionally there are times when a branded medication is more appropriate, and then that will be very much considered by the GPs. We're not barriers to providing the right medication for the right person at the right time when indicated.
Thank you very much, and can I thank all the members of the panel for their evidence today, and we may be in touch if there are matters that we would like to hear more about from the evidence you've given today. We will have our next and final session of evidence on the Medicines Inquiry with the Cabinet Secretary on the 10th of March. So we look forward to that. Thank you very much. We'll suspend briefly and then resume in a couple of minutes' time.